talking about a subject like trauma, I want to make sure that you're okay. I never know where everybody is individually. I know, COVID, lots of things are going on. So, although you can't see me, I hope we can take a collective woosah. Can we breathe in and breathe out together? Thank you. I wish I could see if you were doing that. So you have to acknowledge that you are. You can unmute yourself. So would everybody kind of introduce themselves, or just a few people for 1 minute before we get started? Can you unmute yourself? Yes, you can.
Good evening, everyone. This is Latricia Centers from Chandler, Arizona. I'm a former City of Phoenix employee, and I've worked with vulnerable populations and low-income families for over 30 years through the Head Start program, and I'm excited to listen to Sandra and hear what she has to say about trauma.
All right, thank you. Anybody else want to introduce yourself before we move on? Okay. So I asked, what did you do and what do you hope to learn? I did hear from Latricia. I don't know if anybody else wants to chime in. Maybe just one more person.
Good evening. This is Tracy Hall. I am the Parks and Recreation Director, and I'm always interested in learning more about trauma and how we can apply it to our work.
All right, thank you. Right, so why are we here? One of the things that I want to make sure to emphasize is that you are hearing the expression being trauma informed. You hear it no matter what profession you're in. We're looking at trauma through a different lens. Being informed means that we are using a different kind of perspective, and we're asking the question, what happened? So we want to examine trauma and the effects of trauma to gain an understanding of why exploring trauma is important, increase our awareness of being trauma informed and trauma responsive. So what is trauma? It's a deeply distressing or disturbing experience. A synonym would be a torment, agony, suffering, pain, anguish, misery, distress. It's an emotional shock followed by a stressful event or physical injury, which may be associated with physical shock and sometimes leads to long-term neurosis. A trauma would include a sudden or violent loss of a loved one, position, family, property. It could be substance abuse disorder, which could be personal or someone in your family. A refugee situation or war experience, including torture, serious accident or life-threatening illness, a natural disaster, a military-related stress, a deployment, intergenerational trauma, historical trauma, and a pandemic. So one of the things that happens when one is traumatized, it changes the chemistry of the brain. So if you look at the picture of the brain, you see how this picture, the brain is all lit up. And this picture, there are dark areas because there has actually been chemical change. The traumatized brain look different from non-traumatized brains in 3 predictable ways. The thinking center, the prefrontal cortex, is underactivated, so we're not thinking. The emotional regulation center is underactivated. And the fear center is overactivated. So we're actually using what you all, I'm sure, are familiar with, is fight, flight, or freeze. Trauma can alter brain functioning in many ways, but three of the most important changes appear to occur in the following areas of the brain. Here's a picture of the brain. The prefrontal cortex is known as the thinking center. The anterior circuit cortex as the emotional center, and the amygdala as known as the fear center. That's down here, so the prefrontal cortex is up here. I have a short video that I would like to show you. Open up. I hear someone's child, so, and that's fine. You might want to mute your video.
Our brains are designed to help us survive by making sure we make danger a priority. This is done by the various parts of the brain, called the amygdala, thalamus, hippocampus, cerebellum, prefrontal cortex, full frontal cortex, the pituitary, and the flux capacitor. Got that? Okay, so basically the fear response begins with input from your senses. Together they create an emotional response. For fear, the response is typically fight, flight, or freeze. After emotional events, situations, or feelings, you begin to learn what situations are safe or dangerous. You also begin to develop quick action plans in these events. But this isn't what always happens to someone who has dealt with trauma. They are not able to develop action plans in situations and can't quickly tell if the situation is safe or dangerous, leaving them in a constant state of alert and feel like they are in danger. Think of a youth that tends to overreact. Say a boy trips and bumps into him. The youth turns around, ready to fight, and punches the kid. He felt like he was in danger and never stopped to think that it might be an accident. In adolescence, trauma can interfere with development of the areas of the brain that are responsible for consideration of the consequences, for realistic appraisal of danger and safety, and the ability to govern behavior and meet longer-term goals. And as a result, are at an increased risk for reckless and risk-taking behavior, underachievement and school failure, for poor choices, and aggressive or delinquent activity.
Okay. I would like for you to kind of take notes if you have questions so that we could address them in the end. So trauma responsive care includes considering the impact that trauma has on children and families. Ms. Centers, I'm sure you could relate to that you've seen families that have been impacted by trauma. Assisting staff in understanding and help modifying problem behaviors. Respecting and supporting positive, stable, and enduring relationships in their lives, especially when you're working with children, and creating and advocating. So it might be that in your various positions that you may be the one to be able to identify that one of your clients, your coworkers has experienced trauma, and you may be the one who's advocating for them. Or, depending on your position, you might be providing services. The other thing is promoting staff wellness and self-care. When we work with traumatized populations, we can become traumatized. We are not excluded from it. I've been in the profession over 40 years, and I can still be triggered. I work with students. I teach, and I'm a faculty advisor for Columbia. And my students say things to me, and they tell me things that are still traumatized. I can look at the COVID numbers and become traumatized. So even though I've been in the profession over 40 years, have worked with all kinds of families in various capacities, in child welfare and in mental health, and now teaching, I can still be triggered. Trauma can affect healthy development. It can affect the ability to trust others, your sense of personal safety, your ability to manage emotions. For students, the ability to function well at school, the ability to navigate and adjust to changes, and physical and emotional response to stress. So in my profession, I've worked a lot with children and taught, and I am a field supervisor for students who are working with children. So the impact on a traumatic event depends on the age of a child. Now just think about it. So a child's going to have a different response to a traumatic event if he's 5 or if he's 14. The perception of danger faced, which actually depends on how many times he's experienced before. Does this look familiar? Is this the first time this happened? Whether the youth was a victim or a witness. For at least 8 or 9 years, I ran groups for children who witnessed domestic violence. And their response to witnessing domestic violence was just as significant as the kind of responses that their parents had, because they either saw it or they heard it. The relationship to the victim or perpetrator, if a child is abused by a loving caregiver, a parent, their response to the abuse is going to be different because they feel violated and betrayed. Whether there's past experience with trauma, the adversities that child faces following the trauma. If a child, again, in many cases with the children that I worked with, many times the parents would be sent to prison, they may have been deported. So there are these secondary adversities that go along with the trauma. Maybe they're placed in foster care, so they have to move, and they may move from school to school to school. So we call those secondary adversities. And the other is the presence of an availability of adult who can offer comfort and care and protection. Trauma in childhood can create changes in the child's life that can be challenging and difficult. Leave reminders that may persist for years. We call these triggers. Triggers may include persons, places, things, situation, anniversaries, or feelings such as renewed fear or sadness. I'm sure you may know adults, and you may have actually experienced yourself that maybe a certain time of year that something happens and you're triggered. You may drive by a certain neighborhood. It may be a certain smell. Working with children who've been abused, they can tell me about cigarettes and smelling alcohol and smelling drugs, and that can become triggering. And so there are physical reactions, such as increased heart rate or body sensation. When I'm triggered, my heart starts beating fast. I'm sure that you may experience the same thing, or you may get sweaty hands. And identifying a child's trauma and loss reminder, this is an important tool. So once you become aware of the trauma, if you become aware of your triggers, it will help you to mitigate them. So post-traumatic stress disorder, I'm sure you've heard of that. There was first work done after Vietnam, and they looked at soldiers who came back from war. Post-traumatic stress disorder symptoms may start within 1 month of a traumatic event, but sometimes symptoms may not appear until years after the event. These symptoms cause significant problems in social or work situations and in their relationships. They can also interfere with your ability to go about your normal daily tasks. Post-traumatic stress disorder symptoms are generally grouped into 4 types: avoidance, negative changing in thinking and mood, changes in emotional reaction, they either underreact or overreact, and changes in physical and emotional reactions. So I can't see a show of hands, but I'm hoping some of you've heard of the ACEs study. We call that adverse childhood experiences here. So in 1995 to 1997, Kaiser Permanente, which is here in California, conducted a study The study was one of the largest investigations of child abuse and neglect, and later life, health, and well-being. The original ACE study was conducted in the 90s, from 95 to 97. There were 2 waves, over 17,000 health maintenance organizations sponsored it, and they surveyed several, and they surveyed um, an abundance of clients, patients. The interesting thing about the study, so it started out, Dr. Vince Folletti was actually conducting a weight loss study. And what he found was on the diet that he prescribed, originally the clients lost weight, the patients lost weight, but then some of them gained it back. And when he started investigating and researching why some gained it back, some of the individuals gained the weight back because it was protective. He found that they had experienced these adverse childhood experiences. And then he started looking at all of the patients, and they started this research that lasted 2 years. So the results and the participants, there were 54 of the participants were female, 46 male, 75% white, 11% Latino, and 5% African American. What they measured was abuse, physical abuse, emotional abuse, sexual abuse, neglect, physical neglect, emotional neglect, mental illness, domestic violence. This is mother treated violently. That's domestic violence, divorce, incarcerated relative, and substance abuse. And that's Dr. Vince Folletti. I'm not going to play that, but I would encourage you to look him up and look at the video yourself. And what they found in the study that they did with that population that I just showed you, at least 1 in 4 had experienced over 4 ACEs. And that's generally not the population like Ms. Centers was talking about that you may encounter in your daily work. But 1 in 4, just think about that, experienced some type of ACEs. And what the correlation between the childhood adverse experience showed increased risk in alcoholism, chronic obstructive pulmonary disease, depression, fetal death, health-related quality of life, drug use, heart disease, liver disease, poor work performance, financial stress, risk for intimate partner danger, multiple sexual partners, sexually transmitted diseases, smoking, suicide attempts, unattended pregnancies, early initiation of smoking, early initiation of sexual activity, adolescent pregnancy, risk for social disease, and poor academic achievement. So with the increased number of scores, there's an increased risk, which it's not, so this is probable, it's not predictive. In teaching, I hear students say all the time, well, I got an A score of 9, and I have to remind them, you are not your score. Dr. Nadine Burks is one of the, actually she's the attorney, she is the Surgeon General in the state here of California, and she's done extensive work around ACEs and mitigating factors around ACEs. And I wanted to show you a short video about resilience because I don't want you to, I'm telling you about all of these things, but I don't want to leave you without hope. So this is Dr. Nadine Burke.
My name is Dr. Nadine Burke Harris, and I am the CEO and the founder of the Center for Youth Wellness at San Francisco. The thing that for me is really promising for the field of ACEs and how trauma leads to chronic disease outcomes. When we look in 1983, when the time between diagnosis to death for HIV/AIDS was 6 months. 30 years later, when we look at standard antiretroviral therapy, the anticipated life expectancy is over 50 we look at their increased risk of heart disease or chronic obstructive pulmonary disease or depression or suicidality, folks will say, what the heck happened here? Why did this go untreated? And that's the vision I think that we hold for where we are in scientific. I think that it is rare that you get to be at this point where you get to this part of the tipping point. We have the opportunity to see that the work that we do on a daily basis is reflected in the national conversation. I think that it's rare that I have the opportunity to get the voices of my patients, right, who come to me every day, and then I can take that voice and develop a clinical protocol around it, or I can take that voice and take it to Washington, D.C. and testify before Congress. Like, that is just a totally ridiculous opportunity. In some ways, it's really challenging because things are moving and changing, and we don't have all the infrastructure we would like, and we don't have all the resources that we would like. But on the flip side, we get to see the impact, and we get to be part of shaping and creating our nation's response to the single largest public health threat that our nation is facing today.
And that was Dr. Nadine Burke. Obviously, she recorded that before the pandemic, but we understand her passion, and it gives us hope that we all have a part to play. So I want to talk a little bit about protective and promotive factors that can reduce the adverse impact of trauma. So promotive factors buffer the adverse effect of trauma and its stressful aftermath, whereas promotive factors increase whereas promotive factors generally enhance children's positive adjustment, regardless whether risk factors are present. So promotive factors, protective factors buffer, and promotive factors enhance. If you're thinking of, and I like to use this example of a car, the body of the car is protected. The promotive factors would be your engine. Oops, what happened? It says we'll be disconnected.
Did something happen?
Yeah, it said like we're being kicked out. Okay, all right. Promotive and protective factors may include a child intrinsic factors such as high self-esteem, self-efficacy, and possessing a repertoire of adaptive coping skills. The presence and the strength of promotive and protective factors, both before and after, can enhance children's ability to resist, to recover, or bounce back. One of the interesting researchers found that children who knew more about their families seemed to be more resilient. So after 911, before 911, there was a Dr. Fishhush and Duke questioned 4 dozen families in 2001 and taped their dinner conversation, and then they compared them to a battery of tests. So the children who knew more about their family's history and they had a stronger sense of control and higher self-esteem. After 911, they went back to the same children and they reassessed them with the same study. Once again, those who knew more about their families were more resilient. And you can find this in an article called Stories That Bind Us. And what they used was a do you know scale. It was like, do you know where your parents met? Do you know who your grandmother? Do you know where she's from? So basic things like knowing about your family history creates resiliency in children. Epigenetics is a study of changes in the expression of genes that result from alteration in the sequences of the genetic code. Each person's DNA lays a groundwork for the development of physical and psychological characteristics but the activity of the genes can be modified by various factors like trauma and stress. So scientists who work in epigenetics explore the mechanisms that can affect the activity of genes. In recent years, it's been researched to see whether epigenetic changes resulting from traumatic experience can be passed down from one generation to the next. And that's called intergenerational transmission of trauma. I'm going to show you another short video with Dr. Rachel Yehuda, and she is one of the founders and pioneer in the work of epigenetics.
59-year-old Karen Sonnenberg grew up on the North Shore of Long Island, just an hour's drive from New York City. Her parents survived the Holocaust, but rarely mentioned it.
All I knew was that we were different, that I was different. I didn't exactly know why.
Her parents were Jewish, born in Germany, but after Hitler came to power, their families fled. Sonnenberg's parents were just children, but carried the traumas of Nazi oppression throughout their lives.
My mother, from the time she was 3 on, from my father, from the time he was 5 or 6 years old, he was subjected to the painful existence in Germany.
Despite her own comfortable upbringing here in the U.S., Sonnenberg privately struggled for years with anxiety and stress. And while she couldn't prove it, she believed it was somehow linked to her parents' traumatic childhoods.
Having discussed this with many of my friends who come from similar backgrounds, it seems to be consistent in most of us. There were definitely challenges that quote-unquote American kids didn't seem to have experienced.
Even though you weren't there.
Exactly. That's the amazing part of it.
Now, a new study published this month in the scientific journal Biological Psychiatry bolsters Sonnenberg's belief that she experienced the after effects of her parents' trauma. Dr. Rachel Yehuda, director of Mount Sinai's Traumatic Stress Studies Division, led the study. Her team interviewed and drew blood from 32 sets of survivors and their children, focusing on a gene called FKBP5.
We already know that this is a gene that contributes to risk for depression and post-traumatic stress disorder.
Yehuda noticed a pattern among the Holocaust survivors called an epigenetic change. Not a change in the gene itself, but rather a change in a chemical marker attached to it.
When we looked at their own children also had an epigenetic change in the same spot on a stress-related gene.
What does that suggest?
Well, in the first generation, in a Holocaust survivor, it suggests that there has been an adaptation or a response to a horrendous environmental event. And in the second generation, it suggests that there has also been a response of the offspring to this parental trauma.
Which means children of Holocaust survivors like Sonnenberg could be more likely to develop stress or anxiety disorders. Though their study was small, Yehuda and her team controlled for any early trauma the survivors' children may have experienced themselves. How is it that a parent who was subjected to the trauma of the Holocaust is able to somehow transmit that to a child who wasn't there?
Well, that's a really good question. And this study that we did doesn't address the how. The study that we did just provides a proof of concept that we might be able to identify the how if we do more research.
DNA is passed from parents to children. But research like Yehuda's suggests parental life experiences can modify their body chemistry, and those modifications can be transmitted to children as well. Scientists have examined this idea before. After a famine in Holland during 1944 and 45, children were born with the effects of malnutrition 2 generations after the food shortage ended. Previously, Yehuda herself studied stress hormone levels in children born to women who survived the September 11th terrorist attacks. She's been examining the link between trauma experienced by Holocaust survivors and their children for more than 20 years.
A trauma is an event that changes you, and it doesn't have to change you for the negative. Trauma changes you in lots of different ways, but most people who experience trauma, learn a great deal from that experience. And some of those lessons may be lessons that are transmitted to the child, and that's not a bad thing.
Yehuda says the implications aren't limited to Holocaust survivors, but this dwindling population provides insight into how clinicians understand and treat stress disorders.
If you're at risk for heart disease, a lot of times the doctor can separate out, well, this is your weight, that's not good, this is your diet, these are your genetic risks, things like that. And it would be very nice if we could develop a similar risk profile in the mental health arena, where we would be able to understand where the risk factors come from for depression and anxiety.
We're on the 10th anniversary of Hurricane Katrina. There were children who were born after that trauma. There are children born in the trauma of war in Syria and other crises around the world. If you're the child of a parent who experienced trauma, are you doomed to be depressed or stressed for the rest of your life?
I don't think you're doomed, but I think that many children of traumatized parents have struggled with depression and anxiety, and I can tell you that many of them have felt relief that there might be a contributing factor that has been based on how they're responding to their parental trauma. I think that it's helped people work through a lot of that depression and anxiety.
Relief is exactly what Karen Sonneberg, the child of Holocaust survivors, felt after she participated in one of Dr. Yehuda's trauma survivor studies. She lost her mother 30 years ago, but looks forward to her father's 90th birthday next year.
I've learned to cope in my life. I've learned to move on and get over all of this. Had I known at the time how my reaction could impact future children and children's reactions, I might have dealt with things differently, or gotten them some sort of treatment that maybe would help them in the future.
So I think the study for me of epigenetics is amazing. And if that is true for Holocaust survivors, for victims of 9/11, we have to look at genocide, Native American genocide, when we look at historical trauma, and descendants of slaves. Because if the DNA is changed, as trauma can be passed on in the genes, just as resilience, it gives us context when we're looking at mental health conditions, at history, and context is everything. So right now, I know some of this has been a little much, and I always like to stop and give us an opportunity to exhale. So I bring that up, and I want us to exhale because I want to talk about secondary trauma. What is secondary trauma? The National Child Traumatic Stress Network, which I'm a part of, defines secondary traumatic stress is the emotional duress that results when an individual hears about the firsthand trauma experience of another. Signs that you're experiencing secondary trauma is apathy, isolation, sleeplessness, irritability, unexplained anxiety, anger, headache, stomach problems, fatigue, and mood swings. So secondary trauma is the emotional duress, again, that when an individual hears about firsthand experience of another, the physical and mental exhaustion of emotional withdrawal experienced by those who care for sick or traumatized people over extended period of time. And I think about the healthcare workers that we see nightly on the news in tears. So they are experiencing secondary trauma. So they're not victims of the trauma. They're experiencing secondary trauma because they're dealing with this firsthand every day. Burnout is something completely different. Burnout is caused by everyday work stress, dealing with insurance companies, making treatment choices, and then there's compassion fatigue. Someone who works at the post office can be burnt out. You could be burnt out if you worked at Starbucks. So it's completely different than secondary trauma or compassion fatigue. Compassion fatigue is the result of taking the emotional burden of a patient's agony, and that's by definition by Tim Jarvis. So again, when you're looking at the news and you see the nurses crying and the doctors overextended, of course, we think about first responders, even teachers, social workers, clinicians. When you hear them talking about what goes on in their sleeplessness and their fatigue and their anxiety, that's secondary trauma. So addressing secondary trauma and compassion fatigue, you really have to have an intentional plan. I joke with my students all the time because we deal with heavy topics during our class, and I always say, you know, after we've talked about trauma, we talked about abuse, it is not the time to leave class, and my classes are late in the evening, and to watch, which we love, Special Victims Unit. We all love Mariska. We like the program, but if you've dealt with a traumatic situation or hearing about trauma all the time and loss and grief, it's not the time to watch that. So we talk about limiting your trauma inputs. Create a safety plan for processing. So you want to decide and find out who can you talk to about what you're going through, and ask them permission because they might be going through the same thing. You want to ask your coworker, your friend, someone who you feel safe with, if you can process with them. And of course, if it's extensive, you really should consider doing your own clinical work, seeing a clinician. So if you're in an organization and you are in a place, a position of influence, you might want to acknowledge in the organization that we're all traumatized. And we're all going through secondary trauma. This is it is an important factor to consider if you're working in child welfare or teaching or a clinician. One of the things that I've done in the past is hold groups for child welfare workers, which I used to be one, in Los Angeles, to talk about, give them an opportunity and a safe place to talk about what they're going through. And then daily practices of self-care. Being a martyr doesn't really pay off in this work, right? You really have to address your self-care, exercise, your eating habits, getting enough sleep, because we are the vessel for change, right? We have to take care of this body and our emotional health. And then there are ways of cultural healing or spiritual healing that one might employ depending on what your belief systems are. So create an intentional plan. Or tell my students in supervision, when you leave your job, take off your badge. You know, put your badge, in your car, because you should be leaving one role into another. I've been a child welfare investigator and had young children. And I know that the things that I saw during the day, I didn't want to take home to my children and my family. And I had to be intentional about it. So I like to leave my classes, my presentations, with some food for thought. This is by Brene Brown. Daring greatly means the courage to be vulnerable. It means to show up and be seen, to ask for what you need, and to talk about how you're feeling. And to have the hard conversations. There's an old African proverb that I always use, and it says, if you want to go fast, go alone. But if you want to go far, go together. I hope this has been helpful for you. I hope that I can be of assistance in us going together in your journey to become more trauma informed. And I thank you, and I'm open for questions.
Thank you so much, Sandra. If anyone has any questions, feel free to unmute yourself and ask them.
Any comments?
I personally thought it was really great and definitely very informative, and I'm appreciative that I got the information tonight.
Hi, Sandra. It's Latricia Centers. I really enjoyed this evening's session. I particularly really liked and learned a lot from the epigenetics video. And I have a question for you. What do you recommend to help a young adult who has been traumatized in some way that hasn't really been identified and really refuses to address the person who's caused the harm or the trauma to them, but finds it more important just to suppress it and just feel like if I suppress it, what's done has been done. There's no changing the person, there's no changing the situation because the act has already been committed or the behavior has already been done to that person, and helping that young adult find a trusting adult that can help relinquish whatever's going on inside them so that they're not feeling a high level of anxiety, frustration, anger, resentment towards the individual.
Thank you for the question. We cannot control what has been done to us, right? We can control our response to it, to it. And depending on the situation, it may not be as critical to confront the person about the trauma rather than to the young person that you talk about to acknowledge that they're hurting, that acknowledge that they've been hurt, to seek clinical intervention. If they don't want to speak to a clinician, to be able to share someone what they're feeling and how they're feeling, and to look at how they're coping. Because one of the things that happens is when we bury things down, of course, it can make us sick in other ways, right? It can affect our physical health, like the video that I showed you earlier, where we become very reactive, right? We're triggered easily. It affects our emotion, are able to regulate our emotions. So it's going to be important to continue to offer help, to help normalize. And I think a lot in our communities, and especially communities of color, we are not really open to clinical intervention. We think that it means, there's something wrong. So to normalize the reactions of being traumatized, and to normalize the fact that it's okay to ask for help.
Great. Thank you very much. That was very helpful.
Anyone else? But that was a great question, and it's particularly hard with adolescents. But being present, being consistent, and normalizing. Everybody can use help from someone. Anyone else have any particular questions about any part of the presentation? If there's something more that you would like, and like I was rushing through it, I have to say, most of my presentations are at least 2 hours. I get to look at my participants, ask them questions, use breakout groups, but trying to, make this compact and succinct was a little challenging. So I apologize for that. And for some reason or another, when we did our practice session, my video came on fine. I don't know what happened, but this is 2020, and this is what happens, right? Any other questions? Comments?
All right, well, if there's no more questions, I just want to thank you all for joining us tonight, and a big thanks to Sandra for taking the time to educate the community about trauma. Next week is our last week of the virtual speaker series. The topic will be about child development, helping boys and girls thrive. This will be hosted on November 30th at 5 p.m. Make sure to pre-register for the link just as you did tonight at www.phoenix.gov/parks, and we hope to see you all again next week. Thank you and have a great night.
Thank you.